Now, next lecture will be held by Professor Samia Nasr, Professor of Pediatric and Director of Cystic Fibrosis Center, Michigan, USA. The title is Progress in Cystic Fibrosis Treatment.
مساء الخير. ألف شكر على إنكم عزمتوني إن أبقى معاكم في المؤتمر الجميل اللي شفت السبيكرز for yesterday. Very nicely put. So thank you for inviting me. Today I'll be talking about progress in cystic fibrosis treatment. I am a professor of pediatrics and director of the Cystic Fibrosis Center at the University of Michigan. So cystic fibrosis was started to be recognized in the Middle Ages, actually, and it was at the time known to be if you taste your baby, if you kind of lick your baby and the baby tastes salty, that means the baby is going to die before a year of age. Nothing else came up till 1905 when an Austrian physician described the Meconium ileus, but no more than that. In 1938, Dorothy Anderson recognized the disease by seeing that there were some cystic changes and in the lungs and fibrosis in the pancreas when she was doing autopsies on young children dying young. And that's the name of the disease that came from. And then in 48, there was a heat wave in New York City, and there was a lot of dehydrated children. And that's when they recognized that there was a defect in the sweat gland and lots of loss of sodium. So that's the basis for sweat testing. So cystic fibrosis is an autosomal recessive disease, as most common in Caucasians. However, it affects all other ethnic backgrounds as well. And the incidence is about 1 in 3,000 in the US. However, it's more common in Caucasian. Caucasian is about 1 in 2,500. There is about 30,000 Americans with CF in the country, and actually the number is increasing because they are living longer now. And the adult population is even more than 50% right now. There's about 70,000 patients worldwide. However, that number is way underestimation because some countries don't even test for CF. The genetics of cystic fibrosis, there is about 2,000 CFTR mutations identified. About 160 of them is disease-causing, meaning more common, and the clinical picture is identified. Delta F508 is the most common in North America and in the Western European countries as well. This is a picture of the CF gene, and you can see there are 6 membrane spanning domains, 2 of them. And then you have the regulatory domain, you have the nucleotide binding domain 1 and 2, and the Delta F508 is in the nucleotide binding domain 1. This is how it looks in the membrane, and it's actually a chloride channel, so it allows the chloride to go in and out, and it's an active channel, and that is connected to the sodium channel, which is passive, and that sodium follows the chloride and water as well, and you end up with very dehydrated mucus. So when we talk about cystic fibrosis, now we really talk about the classes of the mutations. So this is the normal people, where you can see that the gene is produced in the nucleus, goes to the Golgi apparatus, and then cytoplasm, and then cell surface, and its function as an active chloride channel. In the class 1, there is no synthesis. So it's actually a stop codon, mainly at the nucleus site. So you end up with a very small piece of the gene, and it does not go out to the Golgi or to the cytoplasm. So this is severe mutation, if you will. For the second group, which is the blocking in the processing of the gene, and that the gene is produced in the nucleus, it goes to the Golgi apparatus to get stronger, and then in the cytoplasm, it's misfolded, the meaning that it's not folded on itself, so it cannot reach the surface, the cell surface. And this includes the delta F508. Class 3, 4, and 5 are mainly the chloride channel reaches the surface, but it's very weak. Either there is blocking in the regulation or altered conductance or reduced synthesis. And that's very important. The classification is very important for the new modulators coming in the market. So this shows you with the abnormal chloride channel. So you can see that the chloride is going more into the cell and then followed by sodium and by water. And then you end up with very dehydrated mucus here. And that attracts viral infections and bacterial infection. And then you get the colonization of these patients. So to diagnose cystic fibrosis, it has to be one of each of these categories. It has to be that you have a characteristic phenotype, features, very important, or if there is a history of a sibling with cystic fibrosis and or having a positive newborn screen, which happen in the United States now, and in a lot of the European countries and Australia, but not in Egypt yet, and hopefully one day it will be. And it has to have a positive sweat chloride. And the sweat chloride testing should be 60 or more millimolar per liter, and it should be in one or two more occasions being positive. Or if you have the two mutations identified, or the abnormal nasal potential difference. Now, keep in mind that the sweat testing is a gold standard, and even if we have the two mutations identified, we still need to have a positive sweat test. These are the causes that can give you elevated sweat chloride, and just so you know that it's not only cystic fibrosis, so that's why you have to have some phenotypic characteristics of CF. One of the things that I always talk about is the malnutrition. So if you have a malnutrition and it's a positive sweat and you think it's CF, you really need to repeat it after the patient is well nourished. Also, if you have G6PD deficiency, again, if you have characteristic features, you are okay with that. But keep that in mind as well, that sometimes if you sweat a patient doesn't have phenotypic characteristics and it's positive, it could be probably one of these reasons. For the false negative sweat, it can happen if your technical or the technicians doing the sweat test is not well trained and doesn't know how to do it correctly. But also if you're not calibrating the machines on a daily basis to make sure that the machine is working well, not only the technicians, but the machine. So that's really important. Some of the antibiotics might give you a false negative. Cloxacycline, can give you false negative, and luckily we don't use that antibiotics. Peripheral edema can give you false negative. So if you think it's CF, after you take care of the peripheral edema, then you need to re-sweat them. This slide is from the latest CF registry data, and that shows you the importance of having a registry. So I'm hoping that will happen in Egypt soon. And that to show us what the characteristics of the disease in Egypt. So you can see that here you have the staph infection early on, and then gradually it interacts here. Then you end up with the Pseudomonas being the more dominant. So the Pseudomonas is not used to be dominant really at around 11 years of age. And then the staph would go down. But as you can see, the curve is moving towards the left side, and that is because of the care that we're providing to CF patients. They are doing much better these days. And then you can see the rest of the infections going on as well. And that's why we are doing throat cultures or sputum cultures on CF patients. We actually repeat it every 3 months or 6 months. So that's important to have a good um, microbiology lab to work with to identify these bacteria. So the clinical presentation mainly include recurrent respiratory infection. And that's why most of the CF patients are taken care of by pediatric pulmonologists or adult pulmonologists, pancreatic insufficiency and increased sweat chloride. Having said that, that doesn't mean it's the only presentation that you would see with CF. It's the main presentation. But you can have pulmonary hypertension, which I don't really see in this country that much anymore because patients are doing generally better. But recently I was talking about CF with the Ethiopian group, and they do have that quite a bit, and right-sided heart failure. About 85% of CF patients have pancreatic insufficiency. There is a lot of steatorrhea, meconium ileus, it's CF till proven otherwise. There is some distal intestinal obstruction syndrome, severe constipation can happen, cirrhosis, splenomegaly, failure to thrive, and the rest of the symptoms here. I'm not going to get to it because of the limited time. So again, like I said, lung disease is the primary cause of morbidity and mortality, and lung colonization infection occur. It's really important to identify which one you're treating. So it is important to do throat culture and know what bacteria you're growing. This slide just summarizes the presentation of the lung disease. You can have acute infection, you can have inflammation, which happen early on. You can have pneumothorax and hemoptysis, which is really caused by most likely an infection. So we usually admit the patients and treat that as infection. Mucus impaction, bronchiectasis, bronchial coughing in a chest x-ray. And there is a score for the chest x-ray that I can go over it later on with you guys. Digital clubbing, and then finally respiratory failure. So these are like the magnitude of the disease from the beginning to the end, really. This slide shows early lung disease, and you can see that there is significant hyperinflation. And then this shows you severe lung disease with quite a bit of damage to the lungs. The CT scans are important, and we use it here often. And you can see that this is in a normal patient, or a normal subject, versus CF patient. And you can see the degree of bronchiectasis and mucus plugging, and then damage into the lungs. And that is a patient with normal lung function. So it tells you that the lung function or the spirometry is not as sensitive, especially in early lung disease compared to later on. There are some studies we are doing here and around the world with using MRI instead of CT because then you reduce the radiation dosing. And that should be really interesting to see the results of. So treatment, just in a nutshell, this is how we do it now, in addition to the modulator, which I'll get into in a little bit. When the patients are diagnosed as newborn screen, so they do not have any signs of disease yet. So we usually start with doing airway clearance and bronchodilator. And the idea is to help maintain the lungs in good shape because they are born with normal lung. So doing the bronchodilator help, and that we do it twice a day. We usually help with opening the airways, and then the airway clearance help move the secretions out. We explain to family that you're not going to see a baby coughing up sputum, but it moves it from the lungs and then they swallow it. We have mucolytic agents like Dornase alpha, and in Egypt we can use a mucomist, which will be working on that. Hypertonic saline is really important, and it can be produced locally easily by a good pharmacist. When patients have infection, we usually do oral antibiotics, IV antibiotics, but also inhaled antibiotics. We use quite a bit of tobramycin inhaled, which is specifically adjusted for the lungs. In Egypt, we usually use gentamicin or can use gentamicin. Aztreonam is an important one as well, and clindamycin is important. We don't use clindamycin that much. It's more used in the European countries, but we do use it sometimes. Anti-inflammatory is important to reduce the inflammation. So we don't use corticosteroids unless there is an asthma picture. Then we use inhaled corticosteroids. We use oral corticosteroids when they have allergic bronchopulmonary aspergillosis. The azithromycin is an anti-inflammatory that we use, and the dosing is different than the acute phase. So nutritionally, we promote high-calorie, high-fat diet, and we use pancreatic enzymes, and it's working very well in that regard. And also we have specific vitamins that are used for CF patients. So, and I know that in Egypt there is Creon, but I don't know how available is it and how affordable as well. So in summary of treatment, you can see that what we're doing right now is, mainly you're having the gene defect right here. So now we have modulators that help correct with the defect right here. It's been working really well, especially the latest one. It's called Trikafta. There are some research about gene transfer and gene editing and RNA editing that we are actually part of at our university here. Then, as I mentioned, important to do the mucolytic and the hypertonic saline, which works as a hydrator and a cough inducer. Antibiotics is very important part of our job, really, and then anti-inflammatory, and then following up to make sure that to reverse any damage happen, even especially if it's early on, like having the CT right now, but soon you will have MRI. So to just touch upon the modulators, which I think is a big topic for everybody around the world, you know that there are 5 classes that we mentioned, and then you know that class 1 is very hard to treat. There is no modulators for it because there is no CFTR to be able to correct. Then you have the type 2, which you have 2 problems with. The class 2 is a misfolding, so you need to unfold it and have it folded correctly. And then you need to get it to the cell surface to work. So you need a corrector to help the misfolding problem, and then you need a potentiator to help open up the gate at the cell surface. So it's very important. Now we know that class 3, 4, and 5 are usually right here. All they need is a potentiator. So we are using ivacaftor or Kalydeco for these patients, and it's working really well. So this shows you what we're trying to do. This is in normal, in patient with no drugs. You can see that even when it reaches the surface, it's not going out because it's closed. But if you use a potentiator, then it will open up and then allow the channel to work correctly. So you can see that in early days, since 1938 till about 1955, the median survival was less than 5 years. There was nothing specific to treat CF. We didn't understand the disease that well, so it was kind of a hit and miss. Then we started to have care and discoveries started, and in 89, the gene was identified, and the median survival was already increasing significantly. Now in 2012, that's when the ivacaftor or Kalydeco was approved, And we put all patients that qualifies for it on it because it was very effective drug. Lumicaftor, ivacaftor, or can be approved in 2015, and I did not put patients on it right away because it wasn't as effective. The results of the studies were not as impressive, but I do use it. And then the tizicaftor, ivacaftor, which is the second generation lumicaftor, it works better, but still not that great, and that's Semdeco. And then from there, they were able to use the tizicaftor, ivacaftor, add another corrector, and then come up with a tricaftor. So this slide shows you the improvement in the sweat gland. So you can see that sweat testing went below below the diagnosis for CF. The FEV1 improved significantly by 10 to 12%. And then they reduced the frequency of exacerbation and improve weight gain. All of that we saw, and it actually continues in patients right now that we're using on. But we really wanted to work on the Delta F508 because it is the most common mutation. So really important to include more patients because class 3, 4, and 5 are only 5% of the patients. So they do have a problem. We need to have something to correct and correctors that are effective and then potentiator. So we did add another potentiator, which is the elexacaftor. So elexacaftor, in addition to the tezicaftor and ivacaftor, they have two correctors and one potentiator, is working beautifully. We are using it in patients with Delta F508 homozygous or heterozygous, regardless what the other mutation is. And that has been very, very rewarding and successful. So this slide shows you that this is the improvement in FEV1 with the ivacaftor, important, significant, and continued. This is when you use the tezicaftor, ivacaftor. Actually, the lumicaftor, ivacaftor would be like this. So it's really a lot worse. But with the triple combo or tricaftor, you can see it's a straight line up. It's been wonderful. I've been using it in all patients that qualify for it. And they've been doing, most of them doing significantly well. Now, gene therapy is being tried, and for the interest of time, I'm just showing you the slide. We're using different vectors to carry the normal CF gene into the cell surface. So it's still ongoing. And this slide just shows you that we are looking at the disease from the very beginning. Like there is a defective gene therapy is being tried, defective protein, then the modulators help with that. And you have the mucolytic agent, the airway clearance, bronchodilator, and then the hydrator or cough inducer, which is hypertonic. And then you use a lot of antibiotics as well. So that's really kind of in a summary. This slide shows you the median survival of CF patients, and you can see that right now it's going up. We don't know where it's going to end. Like I said before, we are used to have 30,000 people with CF, and now we're having close to 40,000. And because they are living longer, they are doing better. Quality of life is much better as well. And that's in a nutshell, the cystic fibrosis coverage. At any time, I would be happy to talk more about it. Each one of these can be dedicated to another lecture by itself. So thank you very much. And I'm looking forward to be with you, hopefully in June, to talk more about cystic fibrosis. Thank you.